Thank you for joining us today for our 2023 Executive Forum discussion. We will get started shortly. We can see a number of people are joining us now. We'll give a few more moments to let everyone get online, and then we'll commence. Welcome, everyone. I'm Denny Brennan. I'm the Executive Director of the Massachusetts Health Data Consortium, and I'm very excited to welcome you to today's Executive Forum discussion in our series, The Road to Interoperability. Today, we are privileged to have two leaders in the health data community talking to us about a critical aspect of the road to interoperability, which is how data are exchanged and how data move in this new economy. Before we get started, I want to introduce you to our forum co-chairs and go over a few housekeeping items, and then I'll spend a little bit of more time introducing our guests. First, in terms of housekeeping, today's session will be an hour, but MHDC staff will be online for the half hour after the hour to continue the discussion, answer any questions, or to maintain an ongoing dialogue about something we may have started in the first hour of our discussion. Everyone is welcome to stay. We understand if you can't, but we've added that as additional time for wrap up and additional conversation. We look forward to active participation and engagement, but because we are operating only within an hour time frame, we'll be watching the clock as our discussion proceeds to make sure we stay on track. We prefer you to share your questions and thoughts verbally. We call this a forum because we believe in the exchange, the open exchange, and creating something as close as possible to the old days when we all sat around a table together and debated and discussed a number of different aspects of health IT, health data, and the like. But we understand that if you are averse or less inclined to speak openly, that you use our chat or Q&A feature. I believe the Q&A feature is the one we would recommend to answer your question, to ask your questions, and we'll take those also. Please feel free to chime in and let your voice be heard. This meeting is being recorded and will be available on our website within 24 hours for our MHDC members. The forum series is free. This forum series is free for MHDC members, and we do offer a non-member registration rate for those of you who want to join us. And occasionally, like today, but not always, we open up our forum for the public because we want to get as much of a wide representation of audience members as possible. We encourage you to look into our website and register yourself for future sessions if you haven't done so. Following today's session, a Zoom survey will pop up, and that will ask you one question or two. And we encourage you to respond to that survey and let us know your thoughts about today's discussion. So now let me introduce our co-chairs for the 2023 Executive Forum Series. MHDC board members David Carusio, who is our board chairperson from Point 32 Health, and William Young from Berkshire Health System. Dave, why don't we start with you?
Thank you, Denny. Very excited about this segment in the series. Welcome everyone to the 2023 Forum Series. I'm David Caruso. As Denny mentioned, we are incredibly delighted to continue the longstanding forum with a new focus on broadening our community, engaging industry and government leaders, and providing dynamic educational experiences for our members. We look forward to seeing you for the remainder of the year. This is the May session, and this is a great session. We've had some really good ones in the past, and we have an incredible round of speakers coming up in the following sessions throughout the year. So we hope to see you for those. And if you're not a member, please consider joining our consortium. Bill?
Bill, you're on mute.
Can you hear me now?
We can.
Got it. Good morning, everyone. I'm Bill Young. I'm the Chief Information Officer at Berkshire Health Systems. I'm excited to co-chair these events with industry and government leaders. Like Denny said, I encourage everyone out there. We got a good attendance this morning. Please engage in the conversation. Interoperability, what a word. Or is it a journey? Back to you, Denny, to introduce these amazing ladies.
Thank you, Bill. Allow me to introduce our guest experts, who I think really need no introduction, but for meeting's sake, I will do that. First, I would like to introduce Mariann Yeager, who has more than 20 years of experience in health IT. Mariann is currently the Chief Executive Officer for the Sequoia project, which is a nonprofit solely focused on advancing secure interoperability nationwide health data sharing. Mariann leads the ONC TEFCA recognized coordinating entity, which helps the ONC to develop and operationalize TEFCA, the Trust and Exchange Framework and the Common Agreement. Sequoia Interoperability Matters programs works to solve discrete challenges to achieve interoperability, such as information sharing guidance, data usability, patient matching, and privacy. Mariann, welcome. Thank you for joining us today. Ruby Raley is also a leading light in healthcare interoperability and is passionate about creating more seamless digital experiences for patients, providers, payers, and beyond. With a focus on APIs and digital transformation, Ruby helps organizations innovate, break down data silos, and secure sensitive information. At Axway, Ruby helps launch Axway products and services, improve processes, and process and position solutions. Ruby has been a consultant and an advisory board member. Ruby, welcome to today's interoperability webinar. So moving forward, the way we operate today is we ask 4 questions of our guests. And these 4 questions are designed first to get their input. And with each question, we will turn to the audience and we will ask you for your input and your questions. As I've mentioned, and as Janice has mentioned in the chat, please speak up or put your questions in the Q&A and we will go from there. Mariann, let me start with you. What are the key methods of exchanging data in this new interoperable world that we speak about? And can you tell us from your perspective, what are some of the pros and cons of each?
Well, certainly, Denny, and thank you again so much for inviting me to join this forum and participate in this dialogue. You know, I have the luxury of being able to focus on one issue and one issue only, interoperability. So we do think about this a lot. And so most of the work that Sequoia has supported to date, and historically we're celebrated our 11th year anniversary this year, has really been around document-based exchange. And, you know, it's interesting when we think about the capabilities that we started focusing on, that we started with one that was so difficult. You know, in retrospect, boy, it wouldn't have been great if we had started with something simpler. So, you know, the benefit of working with document-based exchange is that it's pretty well understood. It's been around a while, it's matured, and it's used pretty extensively with initiatives like Carry Quality, which is a private sector developed framework to interconnect networks, not unlike TEFCA, which is government endorsed. And where they're, I think to date, this year, we're projecting there'll be 3 billion clinical documents exchanged between networks, carrier quality implementers, or the networks, that's what we call them, in 2023 alone. There's a lot of value for that. And, I can talk about and clarify, sort of how we were able to mature that, and it took time, right? It took time to get early adopters and to refine it. And there are lots of things that we've had to do to further constrain the implementation guides, to test, to make sure that there was conformance. But it's taken a lot of work, right? And then, we're hearing very clearly, and I think your community can probably speak to this, more authoritatively, that there's just sometimes too much data being shared in those documents. And sometimes there are duplicates, and it's just a whole mass of data you got to sort of try to parse and make it, more actionable. So there are pros and cons to that, of course, but it is what we have. It's one of the tools that we have in the toolbox. And then, of course, FHIR. And, there's a lot of interest in FHIR. The value and benefit of and pro of that is that it's based on more modern technologies. It's been about 10 years in the making, believe it or not. And, it just sort of makes it easier to, this is a very technical term, to sort of chunk the data and really better enable, really to request and share data, the particular elements that you want and need for particular uses. The downside of where we're seeing FHIR today is that it's not super mature. There are some missing elements that are needed to support automation of it, such as dynamic registration. With our work with TEFCA, we just finished up participating and helped a whole track at HL7 Connectathon, testing out FHIR and the dynamic registration. So it's really kind of in its nascent stages. So while it's simpler to use and implement, we're seeing that it's not ready for wide scale adoption quite yet, but we're moving in that direction. And I think, having a community of practice around it and amplifying and focusing on that work will, through our work with our TEFCA, will certainly help mature it.
Thank you. Ruby, from your perspective, what are the key methods and the pros and cons of each?
Thanks, Denny. I really appreciate this invite, and I echo Mariann's statement about being honored to be here and really in the presence of the pioneers who've been talking about interoperability for many years. In fact, in my early days, I remember speaking about HIEs at one of your live events. So it's nice to see this tradition continue. And I'm going to take a bit of a more technical tack than Mariann did by stepping us down into our old ways of doing things. And at Axway, we still support these 3 ways of files, typically through portals, EDI-based exchanges, often used for administrative flows. And, we had clinical flows, which are like I would say the grandparents of what Mariann is doing with the Sequoia group and the project and the QHIN work today. But there are also APIs. And APIs, while like our original clinical data exchange through IHE, which was real time, but that was more conversational. The new world of APIs is called RESTful, and it's a request response. And by nature, it is built to be shorter, sweeter, simpler, and to the point. And back, in the early days, Mariann mentioned HL7, HL7 convened the payer groups and still does today. And I remember sitting in one where they said it costs $250,000 to build one conversational exchange with one partner. That was just amazing. But if you think about the size of the team, the documentation, the data for testing, the quality control, the actual servers and capabilities, then you could begin to say, well, yeah, I guess, this 6-month project, sometimes even a year project, it could be a lot of people. But with FHIR, we see things coming down tremendously, down into the tens of thousands. But of course, our vision is that it costs nothing because the connections are there and you're consuming them. So The good example that we like to use is utilities, right? So you buy a new appliance and you just plug it into the wall. You didn't have to call the electrician, schedule a project to get the power to run that. And that's what we're looking for in healthcare, is how do we get out of this old, I call it project-based world, into a program-based world where exchanges can change. And you know, Mariann touched on some really important points. So our old ways of doing things, we built in the authentication, right? Because your portal authenticated someone, or your VPN connection had an inherent kind of authentication between endpoints. So we've got to consider, how do we authenticate in this new world? It's a little different for us. And then, one of the other big problems that Mariann also alluded to is data quality and data normalization. Well, part of that project work in the past was the companion guides. How many of us have gone through these 100-page companion guides where every EDI field is typed in, filled out, the team discusses what it means, the team discusses how to validate it. So we've all gone through this, I believe. And now how are we going to do this in a more automated way? Well, we have to pre-agree then on definitions. And that gets us to not only the structure, the syntax, but the semantics of the words. And we don't all use the same words. It's one of our big challenges that FHIR is trying to solve, is we have a clinical domain. And even in the clinical domain, there's subdomains like labs. And we have a claims and administrative domain. And I argue we have a patient domain where patients need things that aren't represented by any of these things. So we're moving from this old sort of batch world to this real-time automated world. And it's automated in every sense. It's automated in, it's now faster and easier to connect. And the way you connect is prescribed. So it's not a project. And it's faster in the way that you can make a request and get a response. So all of these things are changing, but we have to put, one of the cons of moving to this new world is we have to put that energy in up front in order for that utility to be available when we need it. And we can't just assume that we're going to be able to get it all to work if we're not willing to put the energy in up front. So this is one of the challenges the industry is facing. And the last one I'll add in is, if you're a CIO or a CTO, like our colleagues on the call today, you're going to find that budgeting all of this stuff, and what do you do with your existing IT landscape? And this is where we get to this alignment around hybrid. We're going to keep what works for us, and then we've got to find how to build the new world and have them coexist. And I'm going to argue throughout the course of today that we need brokers. We need to be able to broker from our new real-time FHIR API-based world back to our standardized clinical and administrative data exchange world, so that we don't have to rebuild everything to get the value of what we want to do for patient experience.
I like your analogy, Ruby, of appliances and utilities. And Mariann, I'd like, we talked a little bit about this before the meeting, but I think it's helpful to think of TEFCA, the QHINs, and this exchange framework as the grid, in many respects, as that you will be able to plug in and you'll be able to get 120 volts. You'll be able to get, it works for all your appliances. You don't have to have different plugs for different appliances. You don't have to rewire. Could you talk a little bit to that, that notion of the TEFCA exchange framework being the grid of health data exchange? Does that resonate with you?
Oh my gosh, that's such a great analogy. And we do actually use that at different times, because the QHINs are almost like, the different, sort of form the backbone of a power grid, for the US. And so for a lot of our thinking about the expectations of QHINs comes from the idea that we need to have that continuity and that seamlessness, and we can't afford to have brownouts if there is a QHIN that doesn't have the capabilities, the processing power, the financial sustainability to support it, or the technical capability. So there is really, really rigorous set of requirements and vetting that we do to make sure that any organization or network that is designated as a TEFCA qualified health information network really has those capabilities. But really it boils down to, it boils down to just being super practical and realistic about how to make things work in practice, because unless we hit the right mark, if we don't hit the right mark, we're not going to have that sort of seamlessness. And what that entails is getting folks on the same page and understanding and how to implement these standards in a way that can work without any special intervention, and to enable an organization that connects to a QHIN, which is a TEFCA participant, or say they connect through an HIE, a sub-participant, that there has to be the ability for all these capabilities to flow down. And a lot of what we've talked about so far around the standards and how to make that work, but it's also, you have to have the policies and understandings that overlay that. So much of what we think about is that getting to an appropriate level of precision so that how the standards are implemented is so consistent that it just works, again, without subsequent testing or tweaking or configurations, et cetera. So I love that analogy. It's one it resonates really well with us. We also use telecom, sort of cellular networks as an analogy. Banking is another one. What we're doing here isn't so unique. It's just so much more complex, right? And it just takes that additional level of collaboration of how to collectively solve this. And the thing with TEFCA is it gives us this great unifying way of thinking about interoperability, and that it's multi-purpose, multi-utility. So we're not going to establish a network just for public health, or a network just for clinical care, or a network just for giving individuals access to the records, but having all these policy standards capabilities to support multiple purposes. And that's what's so exciting, I think, about what TEFCA brings to bear.
Thank you for that. Let's take a moment to look at our questions and ask our audience what questions they may have before we proceed. I know I can see a number of familiar faces in our audience, and I don't want to do cold calling, but I'd love to hear from a number of you as to what your perspectives are on the key methods of exchanging data. Very good. We could keep moving. We'll continue this conversation. Why don't we go to our next slide? Janice, did you have something you wanted to say?
I think Dave Delano did.
Dave. On mute.
Whoops, on mute. Yeah, sorry about that. I was trying to figure out how to enter a question in the Q&A, and I realized I'm a host and I can't do that. So, but great conversation. Thanks, guys. Do you guys see, the big debate, and obviously in the regulations that we're seeing coming out now, and the development of the SDO development work that's going on, this sort of ongoing tension, if you will, between the old standards, if you will, or the legacy standards, the ones I remember and grew up with and still know and use freely, like X12 and others. Do you see the convergence of the regulatory landscape happening over the next few years, or for how long that's going to take? And do you have any inputs on that? We're just starting to see glimmers of that, certainly with some of the work we're doing with CAQH and some of the other SDOs. That's starting to happen, but do you guys see that? How do you see that playing in here? Either one of you, whoever wants to.
Yeah, we're definitely seeing that there is increased focus, emphasis on promoting the adoption of FHIR-based exchange. And the way we look at it, again, at being super pragmatic, is we don't want to disassemble something that's working. So how can we overlay the more modern standards approach to address capabilities that don't exist today, or sub-use cases of that? But this is not any official, when I'm talking about this here, it's not in any official capacity as the RC or anything. It's just from through Sequoia's lens, we see that there's increased emphasis and focus on it. But what's lacking is, how do you actually implement that? So we work very closely with and IAG and the accelerator projects. Great work, certainly leverage it. we still have to do additional work to get it more precisely constrained. And I love the fact that we're talking about EDI, because actually I used to work at a healthcare clearinghouse a long time ago, and I headed up the payer implementation group in account management support group. So it was sort of our world. And having those companion guides was really helpful. And so we've heard, from folks who lived in that world, wow, where are the companion guides for this stuff? And that's where the gap filling that Sequoia's, stepping in, is we sort of build off the standards, and then we're getting this additional specificity pointing to the standard, but getting more constrained about how we implement it for certain use cases. So I think but it's still not mature to be implemented out of the box.
Mhm.
I
And
would I would agree with that, Mariann. Thank you. As one of the things we do at Axway, of course, is, pitch a API management platform and an API marketplace. Well, one of the things that goes with that is discoverability and then consumption. So you'll see us talking about that all the time. Well, that gets to self-documented or documented, the ability to browse APIs, the ability to try them out. So we have to think through how we're going to do that. One of the nice things about the QHIN is it structures that so that you can, as an organization, decide, if I need patient data, then the QHIN is going to be my way to do that. It takes some of the how do I find this problem off the table when you're trying to do something. But there's still going to be a need for that. And I think that the advanced explanation of benefits is my favorite thought problem, for this, is I already have the ability to do eligibility. I have my, as a payer, I have my medical decision rules. How do I respond to this type of event or symptom that the patient exposes? What is my preferred treatment plan? So that's already encoded as an EDI, for us, or as a combination of EDI and people. So we are going to need, that's what I mean by brokering. It's going to be so much easier for our provider colleagues and the doctor's offices to send a FHIR API. But we, as the plan, may still broker that API over to an EDI document, right? Serve it up using our current capability, convert it back to the API and send it back out. And now you say, well, that's all right, but you're going to need to do that more in human time than in EDI response time. And I agree, but even CAQH has over time had response time requirements in it. So, if we think of this as an evolution and we look at what's out in the marketplace, there is technology that can do this. It is totally possible. It's just that many of us haven't invested in it. So I think one of the key things for a technology leader, either in provider plan or HIT, company, is to understand their landscape and how they're going to step from where they are to the future. And we need to not just do this as a compliance project. Oh, I got to stand up a patient access FHIR API. So that's all I'm going to think about. Oh, I got my team doing that, I'm done. No, we need to think about, we're here today, and in X years, we want to be over here. Okay, so how are we going to move through that stepwise world to get to that future state? And that future state should yield more value than a compliance checkbox. If all we're
Right.
getting is compliance checkbox, it's like,
Yeah, totally agree. I don't know if anybody else has any comments on that, but there needs to be some sort of a roadmap, step, you call them, I think, stepping stones or steps laid out or something of that nature. Because I think everyone's agrees with everything we're all saying. They're just like, well, where do I go first? Like, how do I put that first step forward? And I think that's really where we're at. That's where I see it.
Well, to get to a lower level of detail that I promised I wouldn't get too technical. We do have a customer today that is doing this exact thing. They're brokering conversations between doctors' offices, health plans, and they're doing that between FHIR and EDI. and
Mhm.
they're using their current structure, their current existing ADI structure, but they're also using APIs, and they're mapping and brokering between that, and they're responding to the question of eligibility in real time. So even with today's technology, it's possible. I think we sometimes in healthcare put blinders on, and we think everything is so hard, so complex, can't be done, too difficult. It's not. We're just on the cusp of it. Other industries are doing it. We need to really not be quite so worried about that. And we also need to be careful we don't take the new world and make it look too much like the old world, because then we won't get all the benefits out of doing things in real time and with APIs.
And what's the point of that? That's just reinventing what we currently do. Yeah.
Well,
Right.
it can be in some organizations, because we're looking at time and budget, David, and
Mhm.
you know, I hate it, you know, what did we all used to say? I think Denny will laugh at this. You probably said it too. People who live in glass houses shouldn't throw bricks, right? Because you know, the data center was a glass house at one point, like instead of a cloud. So like, I hesitate to throw bricks, because I've learned over time that most of us are trying to make the right decision at the right point of time. But the problem is sometimes our organizational structures or our goals, our budget, whatever, constrain us to a less than good. And we need to get everyone, executive support is so important to having the mental space and the project space and
Mhm.
the thought space to really envision the future and get there.
Agreed.
Or I think
Thank you.
tech helpful.
Mariann, go ahead.
Yeah,
See you asking.
yeah. So this is where I think TEFCA can be helpful, because we know that we will be supporting fire-based exchange that, you know, tested out the IG just this past weekend, you know, refining it further, but it's all going to be implemented in the context of a use case. And so defining the actors involved in the use case and getting the workflows around it. So, I mean, it's all about implementing into the context of solving a business problem or a business need and a data need. And so that's where, I mean, it's going to be incremental, very stepwise, and we've seen success time and time again by starting small, proving it out, maturing it, expanding. And sometimes, you know, policymakers in particular get kind of impatient about why things aren't working in a particular way, and, you know, to solving all the needs, you know, oh my gosh, why are images, you know, not being shared today? And why is it so hard to get my immunization records and blah, blah, blah. But, you know, we're going to solve it one problem at a time.
I agree with that.
Yeah.
Good question, David. Thank you. Why don't we move on to number 2? And let's ask our panelists to share their thoughts on this. Ruby, you mentioned the patient access API, and we want to kind of learn a little bit more about your thinking about this, and Mariann, you're thinking about this too. How do TEFCA, FHIR, and other technological and regulatory efforts enable this patient-centered health data economy, where patient can access their data, and where this is one of the pillars of our interoperability forum? We have 2. One is the patient experience, and 2 is health equity. How does this go about to improve the patient experience? Can you talk a little bit about that, Ruby? And then Mariann, I'll turn it to you.
Yeah, so use cases are everything. So let's talk about use cases. So, you know, as you read the regulatory guidance from ONC and CMS, right, you're going to see that they're thinking about what I consider super important. So so you'll forgive me for calling them the working poor. So these are people who might be on Medicaid today, but as all the extras, shall I call it, that we added during COVID are taken back, they come off of Medicaid, and they're going to either be on the open exchange or hopefully an employer provided plan. So were they to have a problem, you know, then are all their records lost? Are they in the middle of something? I love to use my husband's back problems, because these things span months. And if you don't understand what he's already done, then how can you put him on the right treatment plan in the future? So, you know, and this is very common if you're someone who is working in a warehouse or standing on your feet all day, you're going to have a back or a musculoskeletal problem that is just a continuing source of issues for you. So how do you move your records back and forth? Well, in a couple of years ago, the old world, there was no way. The health plan would have to pay for the new MRIs, right? The doctor's office would not know what treatments had worked in the past or not worked unless you were lucky enough to be a member of a local HIE. But now in the future, we can think about this information being exchanged and exchanged quickly as I move back and forth. And I would just say further that we have people who move rapidly, like throughout 1 year between plans because of things that have happened to them. And, you know, despite what you may think, I think most of us really appreciate the fact that if you have a pre-existing condition, that you can continue, that you will receive treatment for it. But that just requires data exchange. And the last little bit before, I know Mariann wants to add in, is as we think about the future regulatory things we want to do, like the cost estimators, well, we have to have this foundational information about the patient, but we also need to API enable other things like our costs and our prices and our directories of people who are in network and our scheduling systems. And once you start thinking about, you take your core patient data and your core administrative data and you put those together. FHIR is doing that today, but we have some more work to do to FHIR enable these other things. And with those tools in place, we could imagine that we could build a patient experience. And my current vision is I'm a cancer patient, first time, I'm going in for my first treatment. Could I, on my cell phone, have an API-enabled video that shows me how to navigate the hospital, how to get to that front desk so I don't have to tell the person at the front desk what's happening to me and burst into tears publicly? I can use the video and I can see I need to go to the 4th floor and I need to go here. Oh, and there's going to be this nice lounge for me. And then this is what's going to happen. I can share that with my family members who have to wait for me to pick me up afterwards. And then I have someone who follows up with me on my phone. So even if I don't want to answer the phone, I have a FHIR survey or an API-enabled tool set to just make sure that after that procedure, I'm eating, I'm doing the things I need to do that help ensure that my health improves. Like, we can't do this today without people on call banks. So, you know, the future is we're on this journey and it's going to be so powerful when we can get there.
Thank you. Mariann, what are your thoughts about the patient experience and these efforts to improve it?
So, well, a couple thoughts. One is it's very clear that the 21st Century Cures Act emphasizes and prioritizes an individual's ability to access their information. This is amplified in TEFCA because it's one of the use cases that we're trying to implement. And of course, FHIR is, you know, allows for much simpler devices to be used to access data digitally. I want to channel some of the work that we've done at Sequoia outside of TEFCA. We actually convened a group of consumers who were not involved in health IT at all. These are average people that come from very diverse backgrounds. We're actually going to be publishing a report. And I can tell you, you know, we knew from our board and just to be effective in trying to support individual access to information that we needed to be more conversant on the perspectives from individuals. So the group included 8 people from all walks of life, geographies, socioeconomic backgrounds, different education, you know, just it really, truly. And so 6 of the 8 people are also caregivers. So a lot of times when we're talking about it's the challenges in getting access to information is it's hard as ourselves as a patient, but it's even doubly difficult as a caregiver. So 100% of these folks use a smart device or computer, but 80% of the people they care for don't. And it's interesting because when they're caregivers, that they half the group reported having 11 plus healthcare visits a year. So these folks are very vested in trying to get access to their information. So we learned that they weren't always able to get access to their information and when they wanted or needed it to. So here is the interesting thing, and I'm giving you some highlights from this, was that not all providers have health portals. So if you think about our ability to access health information today, most of it is through patient portals. And there's also difficulty for those who do have patient portals in searching and printing historical records. About half of them said they had difficulty getting access to lab or test results. And then a lot of time they end up spending time doing telephone tag with doctors' offices. So there were a lot of challenges around patient portals. So what we're hoping is that can TEFCA leverage and provide an ecosystem for individuals to more readily access their information through their app of choice, and possibly not necessarily, relying on patient portals, which, most of the time what we heard from them and their experiences were not user-friendly at all. So I think the opportunity is tremendous. There were other challenges though, and these are almost kind of surprising in a way, and they're not technically related. And that was, most of them did not understand their rights under HIPAA. They said that they had no idea that there were networks or HIEs in the background. They did not know that the government had a site like healthit.gov. And so what we could probably solve this technically. In fact, I know we can. And there's some policy issues impeding this, by the way, around, and you all probably know this, that if you are a covered entity and you accidentally release the wrong patient's records, it is emphatically a HIPAA breach, right? So that's a showstopper, right? As we're trying to navigate that to, reduce that. But practically speaking, we are not ready as a country to do this because the average person does not understand how to navigate this system. And we have not communicated and done enough education. And I think we're woefully ill prepared to actually put this into practice at any level of scale.
Thank you for those sobering, but I agree, thoughts about this. The challenges are technical, but they're also cultural.
Yeah,
They're also the level of empowerment that patients want to exercise, some don't. And it's not everybody needs to know how the watch is built, but they do need to know that it tells time, and they do need to know how to read that time in an easy manner. Why don't we move to question number 3? We're culling questions we're getting from the audience, and we'll save those for later. But let's move to question number 3. And Mariann, I'll start with you for this one. How do TEFCA, FHIR, and other technological and regulatory efforts help improve health equity? We've talked about patient experience. Let's talk about advances in health equity that these new technologies and regulatory efforts will promote. What are your thoughts?
Yeah, I mean, TEFCA should be a great level set, right? If it provides an ecosystem for more, standardized and readily accessible information sharing, then that means that better data available, for an expanded ecosystem beyond, what's pretty prevalent today is provider to provider treatment-based exchange. So this is, again, leveling the field and allowing others to participate. FHIR, of course, FHIR APIs have been built around the needs of individuals, and the standards, include race, ethnicity, social determinants of health elements and whatnot in the FHIR IG. So assuming that data is more readily available and it can be studied and analyzed to, then be actionable to have better understanding of disparities. I think that policy, it's definitely a policy priority from what we're seeing. And, we look at TEFCA and FHIR as part of the building blocks to enable that. I think we're ways out to actually implement this. But again, taking incremental stepwise approach is the way to go.
Ruby, your thoughts?
I think that it's essential that we have neutral networks like the QHINs because there's 2 kinds of health equity. There's the equity of the people providing care and reimbursing care in the community. We often can forget that many health plans are small on the exchange. They don't have the technical teams. We like to think of health plans as rich multi-billion-dollar companies, but not all are. And we have the same problem with regional rural hospitals and with doctors' offices who haven't been gobbled up into, an integrated network. So we need to remember that in order for interoperability to serve everyone, everyone has to be able to connect into it. So we have to have that. I'm sorry, the utility just works for me. Utility or telecom service, that base service that has a standardization, that has an affordable connection cost, because we already know there are many clearinghouses, there are many health technology companies who will gather data up and deliver it to you for a fee. But we've seen in industry that these fees can be very difficult to negotiate, and there can be hidden upcharges through the years. So that doesn't work for everyone. So, and as Mariann noted, not every clinical record provider has a patient portal that's actually usable by the patient community. Some of them are so complicated and so clinical that the patient gets little value out of them. So, FHIR begins to take us to the QHIN, the community, and I always think of HIEs as community. So it's the ability to exchange health data within the community that enables people to get the best care. Because otherwise you only get the best care if you can actually talk to the same person who's done everything for you. And that's just not always possible. As we know, like if you're in an accident, you have no control over where you're going to be seen at the emergency room or whatever. So this is all going to help us get there. But as I said before, we have to quit putting our blinders on that all interoperability is just a CCD represented as HL7 or FHIR, or that is a claim or eligibility EDI message and all we did was dump it over into XML and slap a FHIR label on it. No, it's about API enabling the services our organizations want to offer to the community and to each other, because in healthcare is delivered through this network, this ecosystem of providers, reimbursers, supporters, communities, social workers. So we have to enable all of this to communicate, and APIs are something that all of us are landing on. And you might say to yourself, oh, I have nothing to do with APIs. And I say, do you have a cell phone? Do you use Facebook or LinkedIn? And then when you go to get to a new application, does it ask you, do you want to log in with your Google ID? Do you want to log in with your Facebook ID? Do you want to log in with your LinkedIn ID? Guess what? All of that is API and OAuth. It's there. You're using it today. Your kid is using it today. So we have to take that and bring it into our ecosystem to give us this ability to use these building blocks and to make these new brilliant experiences, not only for patients, but for the clinical and administrative communities that serve those patients.
Thank you. Why don't we move? I know I'm mindful of time and we're almost at 10 before the hour. So why don't we move to our fourth question and get our panelists' perspective on that? We live in a world of a hodgepodge of technologies, manual methods, phone, fax, EDI, et cetera, FHIR APIs. There's a mishmash of technologies, but we need to go from where we are to what you both have described as a future, which is more equitable, more accessible, where we use the technologies and the regulatory process. And underneath it all, as you pointed out, Mariann, the 21st Century Cures Act, which is really about, we need to take care of the patient. We need to take care of the individual. Could you, starting Ruby with you, could you talk a little bit about how organizations that are using a hodgepodge of older methods and some newer methods might move to a more modern future? Can you share your thoughts on that?
Yeah, we've touched on this throughout, so I'll just continue to mention, I believe firmly that we need an integration platform type broker to enable us to go back and forth and to deal with some of the data exchange challenges and data transformation challenges. But I want to throw a new idea in at the end here. Mariann sort of alluded to it. We're going to need a data governance edition. And if you think about the HIMSS levels for interoperability, the top level requires some governance and social capabilities. We need data governance. So one of the things organizations need to start doing is tracking how data enters and leaves their organization and for what purposes it enters and leaves, and to look at their population health contracts to ensure that the health technology companies are not monetizing their patients' data without permission and positive understanding of what that permission means. We need to layer that in soon because, you know, we talked about the HIPAA violation. Mariann brought that use case up. That is blocking us. So we're going to have to deal with this governance problem where a traditional hospital doesn't want to release records to a caregiver because the way their old HIPAA privacy and security rules are written, it feels like a data breach, not understanding the newer laws and the newer thinking on this. It's not a data breach because the patient owns their data. So we have to think through that. And I would argue that experience shows us that we are not landing a fighter jet on a carrier. We're landing a massive cargo airplane on a couple mile long runway. So this isn't going to happen as fast as we think. And regulatory deadlines are going to be moved out. So you do have the time to do this right. So it will take time, but you're going to have to think through those governance conversations and thinking about how you exchange data with people who are not a HIPAA entity or covered entity.
Thank you. Mariann, talk about your thoughts about this glide path from today to tomorrow.
Well, I like to think of it as, you know, TEFCA and FHIR and particularly will overlay and supplement what capabilities that exist today. So for example, we talked about carry quality supports network to network exchange, document-based, 3 billion records exchanged between networks a year and growing. And that doesn't even include the document-based exchange intra-network. And it's all principally around patient care, right? Treatment. So we probably wouldn't make sense to stop doing that and to implement new capabilities, you know, using FHIR-based exchange for that purpose if it's working well. So the way we see it is more of an evolution. First, we need to have you know, the FHIR implementation guide implemented by early adopters. We need to learn from that. We need to refine it, tweak it, test to it, expand it further, and likely to implement it for a use case that's not currently supported, such as the exchange of information between a healthcare provider and a payer for healthcare operations perspective. So, you know, it's almost more of a business need that we apply and implement FHIR incrementally for a particular use case or business case, and that complements what we have. Now, we could see FHIR being used to, you know, for more targeted data queries, things like that, individual access. So again, we sort of see it's an additional tool in the toolbox, not necessarily replacing what exists unless it's better. And that frankly is not something that Sequoia would dictate or TEFCA would dictate. It actually would be your community that would determine when it's appropriate to shift and make those changes. And again, I think, Ruby, what you're saying is that doesn't happen overnight. It takes time.
Thank you both. We have a question from Michael who asks, is the danger of breach due to release of information a matter of patient identity and matching? Is it a matter of that being the underlying problem, that when a provider is asked to release data, they don't know that is exactly the person to whom they're releasing the data to?
Exactly.
Maybe Mariann, you could talk to that.
Yeah, exactly. The issue is exactly that. If there is a percentage likelihood that the wrong individual's records could be released, even if it's a small risk, that the concern is, when you talk to the privacy officers and, legal counsel, they're saying, hey, if the wrong record is released to the wrong person because of a patient matching error, then it's a HIPAA breach. And OCR is, basically reinforce that. So that means, we have to have other ways to have a higher degree of assurance that won't happen.
Yeah, I would just add in that the danger of a breach is very rare that you have a reportable breach just because you didn't get one patient right. It's usually in the bulk world or in, unfortunately compromised credentials world that you end up with the challenge of ransomware, which seems to be the most common a really terrible thing that happens to us in today's world. So, but I agree completely with Mariann that people get fixated on this. That's why I said what I said and I started, and really worry about other things. Worry about the fact that you exposed a Fire API without any governance on top of it, and that it can be discovered and there's no credentialing and no authentication on top of it. Worry that someone left a database on your portal open that has information in it that shouldn't be there, or worry that your people don't understand phishing. Worry about that. That is going to keep your name out of the newspaper, off the nasty OCR list. Making one single mistake, that's typically in most states not a reportable problem. You just need to fix it.
That's an excellent point. And that's exactly where we've become so accustomed to being protective of the data that TEFCA and 21st Century Cures Act is changing this paradigm. And frankly, with the information blocking, information sharing rules, it's shifting the paradigm from protecting the data to making it more accessible. And so, that's sort of a tension point, frankly, that we're going to have to help navigate.
One more question we have from David Crucio. How can TEFCA help with prior authorization? We know we have a FHIR implementation guide for prior auth that goes through these steps, but there's a lot underneath that requires some advancements that TEFCA can bring about. Mariann, could you talk a bit about TEFCA and prior auth?
Sure. TEFCA could basically adopt any use case and enable it, and right now we're just included a stakeholder comment period on a payment and healthcare operations implementation guide that contemplates expanding capabilities, like that. I think the first example on the payment side was around risk adjustment, and then healthcare operations is defined by HIPAA. It could certainly point to prior auth. And again, it would be a matter of, what use cases does the community at large have an interest in? And then we would take it through the RCE vetting process and, pilots and make sure that everybody agrees that, how it could be implemented. So TEFCA is anticipated that we would expand the use cases supported over time. It's just trying to find that starter set that is implementable and that would be embraced by the community. And so the feedback we received was start with healthcare operations, generally speaking, and start with a very, very narrow payment use case that and get some experience, and then we can expand from there. But absolutely, we could do that.
Excellent. We're right approaching the top of the hour. Ruby Raley and Mariann Yeager, I really want to thank you for joining us today. This has been an immensely informative hour. A great pleasure to have both of you here to paint this picture. Ruby, I appreciate especially, institutional and practitioner equity, that not all health plans are multi-billion-dollar corporations and not all providers are able to assemble the team and the resources. I think that's a really important aspect of equity that needs to be a part of this. And Mariann, I really appreciate your providing the context, the data standardization and normalization context that will make so much work that is enabled by TEFCA. We really appreciate your time and your attention. And we look forward to talking more with you in the future. You're welcome to stay for the remaining half hour we have, but I understand you both have busy calendars. So you're free to take your leave if you so desire, and with our gratitude again for spending time with us today.
Thank you so much. Really was a pleasure.
Thank you. All right, just to thank you, Ruby. Just to give folks a little bit more time, Ruby will be able to stay with us for about 15 minutes. Just to give folks a sense of what's coming up next, we are going to be participating in a webinar that is the Massachusetts Health Data Consortium with our partners and colleagues at the Network for Excellence in Health Innovation to talk about, surprise, surprise, automating prior authorization. As many of you may know, may not, Massachusetts is embarking on an effort sponsored by the Health Policy Commission and is supported by both MHDC and NEHI to make automated prior authorization the law of the Commonwealth within the next 2 years, in line with the current requirements in the proposed rule from CMS regarding prior auth. This is a very exciting opportunity for Massachusetts, one that will be an enormous challenge, but a great challenge to take on. And we would like to invite you to join. So please, you can register by going to our website. You'll see it on the homepage. We welcome you to join us for that event on the 24th of May between 11 and 1:30. A lot of people, a lot of organizations, and a lot of participants. Secondly, on the next day, the 25th, we're going to be highlighting a demonstration of our Spotlight analytics platform with a focus on health outcomes measures. Some of you may know, many of you may not, that MHDC Spotlight is one of the few tools available that provides comprehensive case mix related data, as well as equity outcomes, low value care related data for Massachusetts and Rhode Island hospitals. We're looking to expand further into New England. But if you want to know how you stand up with respect to community engagement, with respect to low value care, and with respect to health outcomes particularly, we urge you to stop by on the 25th at 2 p.m. and spend some time with us as we share what we're doing in Spotlight. Again, you can access that information at mahealthdata.org. We welcome you to join us for that. All right, so moving forward, our next interoperability executive forum will be taking place on June 8th at 9 a.m. This is where we're focusing on the app ecosystem, the ways in which consumers, providers, every one of us using smartphones, using our digital devices, will start to have access not only to our health data, but to how our health data are used, how we want them to be used, with whom we want them to be shared. And we have some really special people coming to talk with us on the 8th of June at 9 a.m. And they include Jen Blumenthal, the CEO of One Record, Graham Dufault with the App Association, and Jill DeGraff with Be Well Connected Health, who will be talking to us about what is this app ecosystem and how does it work? How do payers and providers enable app connectivity so that patients, members, consumers have as much control as the 21st Century Cures Act envisioned? So we look forward to seeing you there. You see the registration link on the bottom of your page. Please spend some time to join us then. So moving forward, let's talk a little bit. Those of you who are leaving, you will see a brief survey come up. We ask you that you complete it, and we appreciate your help in doing so. Ruby, I wanted to ask you a question. If we could talk a little bit about prior authorization, just as a use case, because we're up to this problem to our eyeballs. And I know that Janice Karen has a question to ask you as well. But in order for us to do prior auth, we need a world where we have the stabilization and normalization that TEFCA can provide. We can find the clinical data where it's supposed to be with the FHIR APIs. Could you talk a little bit about what you see as sort of the major success factors for doing real-time automated end-to-end prior authorization in this new interoperable world?
Sure. I'll start by recognizing that prior auth separate from eligibility, is one of the least automated transactions we have from an EDI standpoint. So my friends at CQH have been trying to get us to do this for years, but many of us still haven't. And, you know, yeah, I hate to exaggerate, but, you know, we all do. So like some providers believe that health plans just deny everything, right, initially, and that prior auth is a way to block providing services. So you probably have read some of this about Medicare people being denied services or too much prior authorization required for a service that is actually available to them in their plan. Well, the health plans are going to say, well, this is something that I need to do to make sure you're taking the best care of my patient as I define that care. So, you know, we can go back and forth on that, but we have to realize that in EDI world, we don't have a good mechanism to attach that clinical data. And so it ends up being a very bulky transaction that often fails in its movement from the doctor's office, who we have to realize is the source of a lot of prior authorization, through some sort of clearinghouse often, because many of them are not direct connected to plans. They're either using a portal and manually putting data up, or they're going through a clearinghouse. So, you know, that big, giant, bulky clinical CCD record or whatever was required, or the actual labs themselves, that's not really it's not well implemented in industry, meaning many have not done it yet. And we haven't dealt with all of the ways we're going to move very large, bulky clinical data or lab data. So we have a gap even in the old world. And now we're saying, oh, we're so surprised we have a gap in a new fire world. Well, no, we're not. We never really solved this problem. So I would say structurally, the things organizations need to do on the plan side is API enable their medical necessity rules so that it's discoverable what data is required to be submitted, right? So the doctor's office doesn't even know what they need to submit until their first request fails. So we need to make that clear. It doesn't have to be through an API, but maybe it could be documented somewhere. But if we're going to really get self-service and pure automation, yes, it has to be automated. I also think that where we're at today is pushing a new conversational pillar that we haven't really recognized. So for example, I keep talking about clinical data and administrative data. Well, who is doing that? Providers, hospitals, health plans, primarily. That's where automation has occurred. Now, to do the prior auth with the doctor's office and to do the advanced explanation of benefits, the doctor's office has to coordinate with the hospital that has the surgery or the care that's going to be provided to the patient and the health plan and all the contractors in between. So now we have new people in this electronic conversation who are not even as connected or as familiar as before. So foundationally, we need to get automation, and I would argue using CAQH type well understood mechanisms. And then we can step into the Fire API world. But if we don't have it automated, Fire isn't going to help us. And I apologize for the background noise.
We don't hear any. We appreciate your apology, but you're coming through loud and clear. I know you obviously can hear it, but we appreciate that. Mariann, what about your thoughts about prior auth? I mean, are you looking at the ways in which, the qualified health information networks, these communities, as you describe them, are going to be able to support and enable a transaction as information intensive as prior? Could you share your thoughts on that?
It's really more of a roadmap issue for us. So we're very singularly focused on rolling out TEFCA with QHINs, and our national coordinator has us laser focused on the payment and healthcare operations and public health use cases. It's on our radar, but we have not really delved into the details of it quite yet. And so again, we're in rollout mode, and we have a focus on getting those first group of QHINs in production by the end of this year. So, I mean, we're kind of just heads down on that right now.
Well, we appreciate that. And we appreciate the fact that the work that is going to enable this is being done, which is a great answer. Janice, you had a question you wanted to ask of our.
Yes, and I'm going to start with Ruby because it's building on something she talked about before. But Mariann, if you have an answer, I'd love to hear that as well. But Ruby, you talked about having a program rather than a project-based approach and doing all of the upfront work to enable consistent data definitions and granular data API support, et cetera. And I definitely approve of that. But what do you say to people who think this sounds like a great approach to take in the future, but who don't necessarily make the connection or the adjustment to think, should I be doing this instead of doing some new secure FTP file exchange or adding more stuff that way or something similar when they're thinking about the actual work?
Well, I had an answer until you threw that example in, Janice. So
Oh,
I
well,
have to rewind a little. I have to rewind a little bit.
You don't
So
have to, it doesn't have to be that exact example.
If you have an FTP exchange mechanism out there and you have any doubt as to its security, you need to immediately take action because healthcare is being targeted. Your organization cannot afford the cost, the reputational stuff, and frankly, the government meddling that will occur if you have a breach, especially due to an unsecured mechanism that you should have known better because they don't have a lot of patience for shoulda, coulda, woulda excuses. So do that now. Take it to your board. You have to begin to understand what risk means. You have to put a cost against risk. And that's true of every type of integration. Even internal integrations can expose things. You know, when you hear about someone who found a database on the internet, that's often just because an internal integration even wasn't properly, secured. So that said, I just fall, I'm a great metaphor person. So, you guys can all groan because I mix them constantly, but you can pay me now and you can pay me later. So if you decide that, oh, this is all the future and I'm just going to do all this stuff, well, that's fine. You still got to do a ton of stuff now and you're going to pay to do it later. If you can be thoughtful about the mix, and Denny knows I'm strong on this agility and efficiency mix. As a CIO, CTO, you have to decide what is serving me well. If it's serving me well, and that means security, operational, business, patient, et cetera, then API enable it or put it in some integration broker, make it more flexible, but leave it alone. If it's not getting you to agility and it's not serving you well, get aggressive about returning it. Now, I don't say that lightly. I've been on the other side of the table where I had a challenge from my CIO to retire applications, and there's nothing harder than to completely close down an application and get finance to get it off the books. I'm not saying this is trivial, but by doing that, you free up headroom on your teams, on your budget, on everything you do to take on something new. So you have to, it's not a or, it's an and. And how do you put the and together? And I think Mariann has said that well several times in her comments today.
Mariann, some of your thoughts on this.
Well, because we are trying to demonstrate real world progress with national level, nationwide interoperability, we're big on incrementalism and sort of taking steps that are achievable so that it's not creating a whole new initiative when we're putting something out for to be implemented. The perfect example of this, and it's a little bit of a departure from what Ruby was touching on, but we talked about it before the meeting started, was data usability is an area that we're focusing on very strongly. We've had a group working on coming up with an implementation guide to better improve the usability and completeness and actionable data, published an implementation guide in December of last year. And now we're moving forward. Well, how do we implement this? It's not something Sequoia would implement. How do we present this in a way that the vendors, providers, payers, others can take steps to implement this? Well, the guide was defined in a way to be implementable, one, prioritizing pain points. The priorities were driven by clinicians, and all to be implementable within an 18-month period. So not trying to solve all data usability and get to the pure state of semantic interoperability, but what can we again do in incremental steps? And when we talked about, and this is all setting the stage for, sort of focusing on sort of a holistic approach to this, was we're now working with the community to say, well, tell us what parts of this you can implement in what time frame. And it's all organized in a way that could be implemented in conjunction with existing projects and programs. So say someone's implementing a new radiology system. Oh, wow, I can knock off 3 of these items in the list, and sort of integrating data usability in everything that you do. So data usability by design, data usability in all things. So it's just part of every project and program that you have is sort of embedded. And so it's not some one-off special thing that you have to prioritize. And, because data usability will never bubble up to number one. In terms of what we heard from CIOs and CTOs, it would never sort of take the place of, say, upgrades or implementing new systems. So that's just sort of our philosophy in all things. That's one concrete example that we're sort of immersed in right now, but it's sort of, again, how do we make progress in an actionable way without trying to fight for priority and resources to do something in one intensive sweep? And it's got to be part of what we do each and every day.
Great, thank you. Dave Delano, you have a question, and you're on mute.
Yeah, I just took myself off mute. Thanks. Kind of back to the comments I heard earlier about, I think somebody referred to the term broker, and I essentially I'm posing this both to Mariann and Ruby because you guys kind of come at this challenge from different angles. Do you guys see the need for those, roles to continue, and how do they fit in this new world, and who is the ultimate place to go to find out where an endpoint is, how to connect to it, what services they provide or have available, and is there a national directory somewhere?
So from a TEFCA perspective, we will support brokered and non-brokered FHIR-based exchange. So there are some, healthcare organizations that don't want an intermediary. They want to implement FHIR in its sort of organic state, and it's sort of designed, by nature to be point to point. We've heard from others, they want an intermediary to do that brokering, that translation. And so TEFCA really contemplates both, and so it allows folks to participate using whatever mechanism they want and need. And we're actually in the process of preparing to revise the common agreement and the QHIN technical framework to support that. And so that's, we're sort of knee deep in that as we speak. We are supporting an endpoint directory. It's FHIR R4 based. It's something that Sequoia supported for other programs. And I think we were the first to actually implement the FHIR R4 directory. And it's implemented, again, for supported now for document-based exchange, but it'll also be the endpoint directory for FHIR-based exchange as well.
Ruby.
Yeah. Hey, so I probably need to define tech terms. This is so fun in healthcare, right? Terms are everything. So when I say broker, I don't mean the same thing that Mariann means. I mean a technical widget that, and I'm trying to avoid like giving plugs to my company or my competitors. So I'm trying to stay away from some terms. But it's a technical tool that can do EDI, files, API, and it can pivot between those. So if a use case comes in as a FHIR API, it could actually be transformed and sent out as a file or an EDI and the reverse. So that's what I'm talking about. So in terms of directories, most organizations, and I leave out the national plans because they might have a special use case. And also I leave out the PBMs because they have a wholly different world as well. Maybe they want to build their own endpoint directories because they touch so many people across the country and they want to own data and they want to own relationships. But for most of us, it doesn't make sense to build our own endpoint directories, right? So that's where TEFCA and QHIN are going to come in because there's too much work associated with doing it and maintaining it, right? And who wants that responsibility? On the other hand, inside your organization, and I use this word whether you're a plan, a provider, or you're the technology company that's offering the services to a doctor's office. You need a similar sort of thing. You need API directories, you need authentication mechanisms, you need a means to do this, and VPN is not the answer. I do not understand why so many in healthcare think every time I want to talk to someone, I want to stand up a VPN. The costs are going to kill you. It's not the right way to think. APIs are meant to be open, right? They're
Yep.
meant to enable things. So VPN is not the answer, but that does mean you need encryption and security, and you need basically a directory and authentication and a gateway around it. So you need to do that within your organization just to enable your own developers and partners to be successful. But you've got to take advantage of the QHIN to enable you to find those other partners. Otherwise, you're building point-to-point connections everywhere.
Exactly my point. Thank you.
Thank you for that. We have just a few minutes before the bottom of the hour, about 10 minutes. Let's consider just one more question before, and I know Ruby, you were ready to sign up shortly. So by all means, thank you for participating. And we don't want to hold you up from, nobody objected to getting out of a meeting on time. So we appreciate your staying with us today. But, you know, Janice, you have a question to ask. Why don't we go to you and we'll make that the last question of our conversation.
Jenny, if you have something to
go ahead.
Okay. Yeah, I actually, we've been talking about TEFCA and fire as if they're two separate things for a lot of this conversation. And I know that there have been some efforts and some approaches to incorporating fire into TEFCA. And I thought it might be useful if Mariann could speak to some of what's going on in that avenue and talk a little bit. I know there's a roadmap out, but it's kind of general. And I don't know if you can say more than what's there, but maybe talk a little bit about that process, and if you can, the timelines and what exactly you see being supported within TEFCA versus happening outside of TEFCA.
Sure. So the first version of the QHIN technical framework really focuses on document-based exchange because that was the capability that was most mature at the time. And so that is what the first group of QHINs that are, there's 6, no, actually we have 7 applications that have been approved. And so we have 7 networks now that are, working on completing their project plans and completing the technical work and testing before they are designated. So that is all based on document-based exchange. That's what they're preparing for an initial go live. And if the rollout occurs similar to a way that Carey has with Carey Quality, it takes about 2 years to get it, early adopters, and folks connected, and maybe 2 more years to reach scale. So that's on that trajectory. So we are in the process of starting to revise the common agreement to support fire-based exchange because there's a paradigm of non-brokered exchange that is different in the document-based world. It assumes there's an intermediary, that the QHIN is the intermediary. And so we have to change the policy side of it. We have an implementation guide a fire-based implementation guide that went out for stakeholder feedback last year. It's gone through 2 rounds of testing, first in conjunction with an IEG Connectathon in February, and then just this past weekend at an HL7 sort of Connectathon. The main thing we're trying to test out and prove is the maturity of the I'm not even going to remember the name of it now, the dynamic registration. So then the idea is that we're revising that implementation guide yet again, because we've learned, right? It had never been tested before February. Dynamic registration had never been tested by anybody. And so it's super in its nascent stages, and it's necessary to have fire at scale, right? So then we're revising the IG. We'll have that fire IG finalized and approved by ONC for implementation in 2023. And then the idea is that we will integrate the fire IG into the QHIN technical framework, so it's not a separate document. We anticipate the rollout of it will take place in early mid 2024. And this is for non-brokered. So this is the point-to-point piece. And then the fire roadmap needs to be updated because the timing is, off a little bit from what was contemplated. We'd like to actually go ahead and just include the brokered fire into the next version of the QTF as well. Because Carrier Quality already has an implementation guide that does both. And we're able to leverage a lot of that, that work that came out of the private sector. So we're looking at an initial rollout of fire-based exchange in 2024. And that's in parallel with ramping up document-based exchange. So it's, it's going to probably follow suit 2 years early adopters, another 2 years for them to get critical mass, another 2 years for really get to scale.
Thank you. This is a fascinating discussion, and at MHDC, we're anticipating getting ourselves into this mess with vigor and excitement and the necessary amount of dread, I think, that goes into it. But we really appreciate, Mariann, your joining us today and sharing your perspective. I like the analogy of the electrical grid. I like the idea of we're building a grid, and at the same time we're starting to think about the appliances that we'll need to have and how they'll serve a variety of functions, knowing that we have this stable, real-time, dynamic foundation that allows for these data to be where they should be and accessible and usable, which is a huge, huge order. And we commend you and the Sequoia project for the work that you're doing there. I want to thank you, and I want to thank everyone in our audience for joining us today. We're just a few minutes before the bottom of the hour, and I know that people appreciate, I've never complained about getting out of a meeting a few moments early. So with that, we will ask that we adjourn, and we look forward to seeing you next month. And again,
Yep.
Mariann, thank you so much for your participation.
And
your
thank you to
insights.
Ruby too, even though she's already left.
And thank you to Ruby. Yes, absolutely. So with that, we'll adjourn. Thank you all.